So I thought we'd talk a little bit today about sort of where Coag might be going in the future. So kind of the outline for the talk, we'll talk a little bit about bleeding versus thrombosis and thrombotic risk. I'll give you a little introduction into thrombin generation assays, which are sort of a new set of assays that we've been looking at over the last couple of years, and then how they might be used for risk assessment in venous thrombosis. We'll talk a little bit about what microparticles are. And then microparticle data that's out there at the moment in heart disease and cancer. We'll talk a little bit about microparticle assays, and then in the end we'll kind of conclude and see where this all might be leading. So if we think about Coag right now, it's sort of a balancing act, right? You've got things that prevent bleeding like the coagulation factors and platelets. You've also got all the things that try to prevent thrombosis, inhibitors like antithrombin and protein C. You've got the endothelial cells, which are active metabolic cells that try to prevent thrombosis normally. And then you've got also the fibrinolytic system, whose job is to dissolve clots and keep them small. So the idea is plug the hole if you get one, don't plug the vessel, right? And so when we think about sort of the things that can go wrong, we've got the bleeding disorders, and typically these are things where you're missing something. Factor deficiency, platelet deficiency, thrombocytopenias or platelet dysfunction, and relatively speaking, only a small portion of the population actually has a typical Coag disorder. They've got some kind of a bleeding disorder. If you looked at the whole population, it's probably less than about 5% of us have some form of just, Coag disorder that's going to lead to bleeding. On the other side, if you think of thrombotic disorders, well, now we're talking about on the arterial side, myocardial infarction, heart attack, stroke. On the venous side, deep venous thrombosis, pulmonary embolism, and then there's sort of the mixed syndromes like where you can both have arterial and venous thrombosis like heparin-induced thrombocytopenia and antiphospholipid antibody syndrome. So if we look at these, this is a significant fraction of the whole population, right? One-third of us are going to die of these things, and probably half of us are going to have some kind of disability associated with it at some point. And so they're a much higher fraction of the world is going to have a problem associated with thrombotic disorders and bleeding disorders, and yet most of the Coag assays we have are really aimed at the bleeding side of things. So we have the PT and the PTT, fibrinogen factor assays, platelet function. These are typically designed to evaluate hereditary or acquired deficiencies or dysfunction of the Coag proteins leading to increased bleeding risk, okay? Reasonably good clinical ability to predict who's going to bleed from these assays. And they're pretty good at detecting what the cause is and telling you what therapy you need to do. But almost all of these assays are telling you the same thing. They're telling you whether you have gas in the tank, right? They're just telling you how full the tank is. If you don't have enough gas in the car, then it won't run very fast. They're not telling you about how fast the motor's running. They really don't tell you anything about the motor. They just said, assuming you have a motor and you have gas, it usually works pretty well. So what we're really going to be talking about is assays that are trying to assess the motor. Is it running too fast? Is it not running fast enough? And if it's running too fast, then what the risk might be. So on the thrombotic side, like we said, it's leading cause of death and disability in the United States. So you've got atherosclerosis and arterial thrombosis of various sorts, venous thromboembolism. And then sometimes we don't think of it as much, but there are often thrombosis-associated phenomenon associated with a lot of the other disease entities that we deal with. Cancer or sepsis or other things often have as a terminal event or associated morbidity a thrombotic problem. So you've got Trousseau's syndrome and cancer, etc. So it's a very common problem. So what do we do for testing in the lab? Well, we do things like cholesterol and lipids, and there may be a few other assays that we have on the arterial side, but most of the time it's some kind of a lipid panel in a sense. So the question is, are we doing a good job of predicting individual risk of thrombosis in patients? And is there the potential that we could do better at that? So that's what we're going to talk about a bit. Now, if we look at the hemostatic factors that potentially affect thrombotic risk, we've got things like the coagulation initiators, things like tissue factor and procoagulant phospholipid that activate the system, initiate it, get it going. We've got the coagulation factors that sustain it, all the things that are part of the cascade, 2, 5, 7, et cetera, that generate coagulation activating factors, eventually leading to thrombin. Thrombin activates fibrinogen, you make the clot. Elevated levels of some of these things have been associated with increased risk, and we now routinely look for persistent elevations of factor VIII as a risk factor on the venous side, but it'd be interesting if we could sort of look at all of these things. Platelets, of course, play a role in preventing clots, but they also potentially are a risk factor on the arterial side. And you have the inhibitors. We talked about protein C, protein S, antithrombin, tissue factor pathway inhibitor, one we don't measure as often. And then you've got the vessel wall, endothelium, atherosclerosis. So if we look at this, and we looked at some of those factors, what do we routinely measure in the Coag lab? Let's say for venous thrombophilia. You're trying to work somebody up to understand why they have a risk, potentially, of venous thrombosis. And so the ones that I've highlighted in here in yellow are the kind of things that we have on the thrombophilia panel that we all look at when we come to rounds in Coag. Antithrombin, protein C, protein S, factor V Leiden or one of the other factor V mutations, antiphospholipid antibodies, maybe persistent elevation of factor VIII. Most of the rest of these things, though, we really don't evaluate very often. Tissue factor pathway inhibitor, the other factor levels. We sort of look at factor II. We're looking at it to see if you have the prothrombin mutation, and that predicts higher levels of factor II. So you could say, in a sense, that we would also potentially evaluate that one. But we don't have any way of sort of looking at them overall. We don't have a PT or a PTT for the thrombotic side of things. What we have are individual assays that we do, and each assay predicts a certain degree of risk associated with it, but we don't really have an overall way of evaluating things. Now, if we look at the arterial side and sort of this same group, really the only thing we routinely measure are antiphospholipid antibodies. You could sort of look at people's fibrinolytic system, but we don't do that very often. Most of these other assays really don't have a tight association with arterial thrombosis, so we don't work people up for those. And so we really have a pretty limited thing that we can do. I mean, it's a couple of assays maybe on the arterial side from Coag. And yet, it's the most common thing that's basically going to cause our death and disability along with cancer. So for thrombotic risk assessment, our sort of current paradigm is measurement of individual Coag factors or inhibitors that lead to an increased risk of thrombosis. Cholesterol and other lipid testing for hereditary thrombophilia on the venous side, we have individual assays, and the risk is kind of based on population averages for people with similar traits, so that if you have antithrombin deficiency, then we can tell you that you're this much more likely to have a thrombosis than the population. The trick is that a lot of these things are pretty low probability in the population. Antithrombin is somewhere between maybe 1 in 500 and 1 in 2,000 individuals. Protein C and S are kind of similar numbers. So if we find them, it's interesting, but in most people, we don't find them. So an individual's risk, at least this would sort of be our hypothesis, would be the sum of all these things. You really want to look at all the Coag factors that are sort of procoagulant, and really all of the inhibitors. And if you could do it, you'd want to look at as many of these things as you could simultaneously to see how they all add up. Because what you'd sort of hypothesize is that, well, if you had sort of a modestly elevated level of maybe 3 or 4 Coag factors and a slightly low level of maybe 2 or 3 of the inhibitors, that might add up to increased risk. But we wouldn't detect that at all at the moment. Because we would say, well, your factor VIII really isn't too high, your antithrombin really isn't too low to be a hereditary deficiency, so you don't add up to anything. And yet, there's this sense that just from looking at sort of the clinical literature, that there's families that have, say, a factor V Leiden mutation, and essentially everybody in the family that has the mutation often develops venous thrombosis. And we'll see these kindreds where they're well described that pretty much if you have it, you get thrombosis. And then there's other kindreds where they will discover that somebody in the family has a factor V Leiden mutation and they have no thrombotic history. And they really don't find anything. In fact, they started this, if you go back to sort of the story of protein C, when they were doing sort of population surveys for protein C deficiency, they found that it was something like 1 in 500 in the population, but that only about 10% of the protein C deficient families seemed to actually have a thrombotic phenotype. And so they said there's got to be some other thing going on. There's got to be some other cofactor that's associated with protein C that ends up, if you have protein C deficiency and something else, that is the people that have thrombosis. Well, that turned out to be factor V Leiden. It's fairly common in the population, right? Northern Europeans, it's going to be something like 7 to 10% of the population have it. Other populations, it's much lower. And so they added that up and said, okay, that was kind of the answer. But we still don't have something that's adding all the pieces together. So that's what we kind of want to look at. Is there a way to measure sort of an overall risk in an individual? So one approach to this are these assays called thrombin generation assays. And what they do is they measure the amount of thrombin being produced in plasma following recalcification with or without an optional tissue factor stimulation. And so essentially what you do is you take plasma and you add a fluorogenic substrate that measures the amount of thrombin that's being generated in the sample, and then you add calcium with or without a tissue factor stimulator to start things going. And we also add a little bit of what's called corn trypsin inhibitor, and this is something that blocks contact activation. Because we have this contact system, and if it gets activated, it activates and generates factor 12, and 12 activates 11, et cetera, until you'll get clotting that way. That's what we do in the PTT. Of course, if you're missing your contact system, you don't have a bleeding syndrome, and you just get a long PTT. So we don't want the contact system to activate in this, because in people, it really doesn't play a role in Coag in the rest of us. It's useful in the lab. It's useful for activating PTTs, and when it's not present, it drives us crazy. But we don't want it to activate in this. So in the simplest version of this, all we're doing is blocking contact activation and adding calcium and seeing what happens. And you know what? If you're healthy, nothing happens. For 60 to 90 minutes, nothing happens. If you recalcify blood and have the contact system blocked in a healthy person, basically nothing happens. It makes sense. We really don't want your blood, and which is full of calcium right now. I hate to tell you this, but you're all recalcified at the moment. And you don't really want clotting going on everywhere, right? And it shouldn't. And that's what happens in normals. So this sort of shows what a thrombin generation assay result looks like. And so what you can see down here is we recalcify here, and thrombin generation, the amount of thrombin that's being produced is sort of shown on the y-axis, and this is time, and we let it run typically for about 90 minutes, so it's quite a long assay. And so what you get is a period where there's no thrombin generated for something on the order of about 5 to 10 minutes, and then you get a big burst of thrombin generation, and then it will essentially turn off again and come right back down to baseline. Now this is the curve we get if we add a little bit of tissue factor as a stimulator. Now to give you an example, we add tissue factor in the ProTime assay, and we add a little phospholipid and we add calcium. So you'd say, well, how is this different than a ProTime? Well, in the ProTime assay, we're adding about 1,000 to 10,000 times more tissue factor. So it isn't subtle. It clots in 10 seconds, essentially, right? Something like that. Okay, in this one, if you just recalcify it, but you don't add any tissue factor at all, you get this lower curve. So this curve is an example of one in a typically normal person, and maybe after 60 minutes you get a little tiny bit of thrombin generated. So we add a little bit of a tissue factor stimulator, and that's sort of what we're doing when we add the little bit of tissue factor is we're sort of simulating what happens in a wound. Wound has a very low concentration of tissue factor present, and you actually get a similar curve. The only thing I think the bleeding time is still useful for, if you wanted to do sort of theoretical studies, if you actually sample the blood coming out of a bleeding time wound, and you measure how much thrombin is in the blood over time, you get a curve that looks like this. It takes a few minutes for things to start up, and then once you start making thrombin, you fairly quickly will start plugging the wound up, and you'll get the platelets sticking to it. So you can get this kind of a curve sort of out of a bleeding time. So this is kind of our standard new test, you might say, to evaluate at least some kinds of thrombosis. We're going to measure how much thrombin you make when we stimulate you with a known amount, small amount of tissue factor, and the kinds of things that we're going to measure are the lag time. How long does it take for this to start? The peak thrombin generation, what's the peak amount that you generate before you start back down again? What's the area under the curve? That's the total amount of thrombin you make when you activate it. And then what's the termination time? How long does it take for the system to shut itself down again? Now what's interesting is each of these things correlate with something different in the blood. The lag time correlates with how much circulating tissue factor or phospholipid you have, particularly when you do what we call the native thrombin generation, meaning all we're doing is recalcifying and blocking contact activation. In a healthy person, probably in 2/3 of the population, we get no thrombin generation at all for 90 minutes. If you get thrombin generation there, it means that you must have something circulating in you that's activating Coag. So lag time correlates with tissue factor or other things that are activating the Coag system. Peak thrombin generation really correlates with the level of coagulation factors that you have. The higher your factor 2 level, your prothrombin level, the higher your factor 8 levels, the more peak thrombin you'll have. And that correlates too with area under curve. Now the termination time correlates with your inhibitors. The higher your inhibitor levels are, like antithrombin, protein C, if you do the assay in the right way, the faster it will shut it all back down again. And the lower the levels are, the less the slope will be, or the longer it will take before you shut it all down. So it's sort of a mini view of the whole Coag system. What's activating the system? How much thrombin do you make due to the procoagulant things? How fast can you shut the whole thing off? So let's look at this and how they've used this to sort of look at recurrent venous thrombosis. So I'll talk about 2 studies totaling about 1,100 patients. All had a prior history of venous thrombosis. Thrombin generation was tested after they had been on warfarin, typically for about 6 months. They followed the people for about 4 years, and the endpoint was whether they had recurrent venous thrombosis. So in one study, in JAMA, this study looked at about 800 patients. What they have is showing you how much thrombin they've made, greater than 400 nanomoles at peak thrombin generation, 300 to 400 and less than 300. And they used as sort of their baseline the ones that had greater than 400 as a risk factor, relative risk of 1. And if you had an intermediate level, then your risk was about half as much. And if you had less than 300 nanomoles of thrombin generated, then your risk was about 1/3. So in other words, the individuals that made the least thrombin given a tissue factor stimulation, they had about 1/3 the risk of going on to have a recurrent venous thrombosis as the individuals that made more thrombin. So this was like the first study essentially showing this. And so the idea was you could do this test after somebody'd had 1 DVT, and potentially the future studies are looking at is maybe the guys that are making more than 400 should be left on warfarin. Maybe they should be on warfarin permanently, or they should be on it for a year, etc. And the other individuals, maybe they don't want to, because we're always trying to balance that bleeding risk on the front slide, right, from the thrombotic risk. So if we could decide which patients need warfarin for longer and which ones don't need it, particularly on those guys that don't need it, then we've really wiped out a lot of bleeding risk, because in a lot of these people, the risk of bleeding long-term on warfarin is roughly of the same order of magnitude as the risk of the thrombosis. Now, thrombosis is a bit worse, so that's why we put people on warfarin. It's a lot worse for the first 6 months. But then later on, you're really trying to sort of control those 2 risks. What's the risk of bleeding? What's the risk of thrombosis? And if you could find a group of patients and say, this group clearly has a lower risk of thrombosis, then you maybe take them off the warfarin. Maybe they don't need to be on it as longer. So this is something that it's sort of averaging the whole Coag system. And it looks initially like it's going to predict risk. What about thrombin generation in another study? So this one, slightly different units. They were looking at the total amount of thrombin generated under the curve. They basically just split it into 2 halves. Top half making the most thrombin, the bottom half making less. Again, what they found is if you were in the bottom half of the group, if you were making less thrombin, your risk of having a recurrent venous thrombosis was about 1/3 as much as the group making more thrombin. So similar numbers and a similar kind of risk profile. Now, it was interesting that in the first study, they sort of eliminated people that had protein C deficiency or antithrombin, et cetera, so that they didn't have anything else going on. This study didn't do that. They just said, let's just take all comers. We don't care if they have some other thrombophilia at the same time. Let's just look at everybody and measure this. And then they compared it against those others. So it turns out that if you had antithrombin deficiency, protein C or protein S, those are some of the stronger but less likely thrombophilic problems, that those individuals were also at increased risk. If you had factor V Leiden or the prothrombin DNA mutation, elevated factor VIII levels, things that give you a mild risk of having a first thrombosis, those individuals basically fell out of the study. When you looked at the thrombin generation, they had no increased prediction of risk, and the only thing that was overall a good predictor was the thrombin generation assay. It basically picked out the people that had risk, and the other assays sort of all fell out in sort of a multivariable study. And so that was sort of interesting, because maybe this is the study you do after you've had one at least. They weren't really looking at this prospectively to see if you're trying to predict in the whole population who might have a first DVT, because this was sort of enriching the population by starting with people that had had one. But there are interesting studies and initial ones going on. So this might be something we do. If you've had one DVT and you want to decide if you really have to have lifelong warfarin or not, then we would do thrombin generation assays on you in the future to sort of decide how much warfarin you need or how long you need to get it. So in a sense, this is what the thrombin generation assays can essentially evaluate. To some extent, they evaluate the same factors that we do individually, but they're evaluating overall in sort of an average. Plus, they evaluate a lot of other factors. So they're adding all of these things up at once to see what the overall picture is. So you could imagine somebody that maybe has factor V Leiden, but simultaneously they have a low level of some of the Coag factors. Not enough low to make you bleed, but maybe they're 70% of normal, that's just the way you are. Well, maybe that person isn't at risk. That's sort of what the question is. So risk of recurrent DVT, thrombin generation independently predicted risk of recurrence. Individual factors were variable. There was really no or low risk associated with factor V Leiden and prothrombin DNA for recurrent venous thrombosis. Variable risk depending on the study you looked at for protein C, protein S, and antithrombin deficiency. Elevated thrombin generation was seen in about a third of the venous thrombophilia patients, while protein C, protein S, and antithrombin deficiency are only seen in a few percent. So the other piece of this puzzle is that this assay predicts that about a third of the population is at increased risk, whereas the other assays we have only predict a few percent. If you have antithrombin deficiency, that's a bad predictor, but only a few percentage, in fact, only a fraction of a percent are antithrombin deficient. So most of the time when we work them up, we don't find anything. With thrombin generation, most of the time we work it up, we would tell you one way or the other. On average, you're at increased risk, or on average, you're not. Next thing I'd like to talk about for a minute is the acute coagulopathy of trauma. This is associated with severe trauma and shock, typically shows a prolonged pro-time and a variable decrease in platelets and fibrinogen. Patients may have massive bleeding that's difficult to control, and typically it's a clinical diagnosis. Mechanisms are still a little unclear, and the laboratory diagnosis is difficult. The classic kind of patient we would see at Harborview if this comes in severely injured and often has completely normal coags when they hit the door. And we start resuscitating them, we give them IV fluids, we warm them up, etc. 45 minutes later, everything's gone. So the question is predicting which one is going to do that versus which patient 45 minutes later is still doing pretty good. And right now we don't know. We just have to wait. 45 minutes later, we get another emergency hemorrhage panel, and we see that, oh, this is one of the guys that is crashing. Could we do something that would predict which one is going to go into this acute coagulopathy and which one's doing okay? Or at least that they're not likely to go into that kind of problem. So again, this is just that same slide I showed you for normal thrombin generation. This one has the tissue factor stimulation, and this is what it looks like if you don't add any tissue factor and you just recalcify. So this is a trauma patient with acute coagulopathy of trauma. And what you see is the same thing. The dotted line has where we've added tissue factor, and the solid line is where we didn't add tissue factor. And guess what? They're almost the same. So in other words, the trauma patients have something circulating in them that activates them essentially to the same degree as we're getting in the test when we add tissue factor and phospholipid as an activator. So sort of looking at a group of these patients, we looked at normal individuals, patients that had trauma but didn't show evidence of coagulopathy, and then individuals that had trauma plus acute coagulopathy. And so what you can see is that the pro-time goes up just a tiny bit on average in trauma, but it's much higher in the trauma with coagulopathy patients. Platelet count is lower, fibrinogen is lower, and the best predictor of all, interestingly enough, was the ratio of thrombin generation to factor II levels. Now, if you look at these patients, they've been injured and they're bleeding and we're resuscitating them and we're diluting them with fluid, so they almost all have low Coag factors, right? Because they've been bleeding and we've been diluting them. So if you take an average person on warfarin and you do this thrombin generation assay, you'll see low thrombin generation because they have low Coag factor levels. On the other hand, if you take these trauma patients, they have low Coag factors, but they're making way too much thrombin. So the sort of ratio of how much thrombin they're making compared to how much Coag factor is way out of whack. So it's about 10 times more thrombin than they should be making, sort of based on how much Coag factor they have there. Now, the other things that we looked at were sort of an assay for overall procoagulant activity. In other words, anything that would initiate the system and how much tissue factor activity they had. In a normal person, essentially, we can't detect any tissue factor. It was below sort of the detection limit of the assay, 0.6. On the other hand, in a trauma patient, they all have a little bit of circulating tissue factor, and in the ones with coagulopathy, they have a lot of circulating tissue factor. So this was a different assay that essentially goes along to show something very similar to what we saw in the thrombin generation, in that they have something circulating that's activating them. So if we could have a very rapid assay for something like this, it'd have to be really quick. We might be able to tell them that we think this person that's coming in is at risk of going into this coagulopathy, and then maybe there'd be in the future a treatment for that. So in summary, in this group, trauma patients show increased in vitro generation of thrombin in plasma, even though the Coag factor levels are reduced. And the trauma patients have increased circulating procoagulants, of which about 74% is tissue factor. So then the question became, what form does the circulating tissue factor take? So now you can guess, this is where we're heading into the next thing. So first of all, very quickly on tissue factor, it's a transmembrane protein. It has an extramembrane portion, transmembrane, and sort of a signaling part inside. It really wants to be in a membrane that has anionic procoagulant phospholipids in it. And then what happens? Well, factor 7A comes down and binds to it, and then factor 9 or 10 comes down, and then the factor 7A activates the 9A. I have a 9-year-old son, Ian. I showed him this, which took me like an hour and a half to make it do all this. He said he thought it was a little weak, Dad, and for a low price he could fix it up for me. He does, his PowerPoints in 3rd grade, and they have 9 guys dancing around the room and shooting things and all that. And so I said, well, maybe next time if I have more time, I'll hire your services. So we're trying to figure out, what are these things? How could this be, what is the circulating form of tissue factor? And so the question is, maybe it's microparticles. So what are these things? Well, they're cellular membrane fragments that are released into body fluids. And I appreciate, for some of you that recognize your slides, like Sandra up there, I have stolen from you wherever I could, because all the residents do these nice presentations, and then without any, thing, I've stolen their best slides out of all their presentations. So, you can see what you presented here. I'm sure you'll all recognize your piece of my talk, and I appreciate it. So there are pieces. They result from membrane blebbing of cells upon stimulation, injury, induction of apoptosis. Essentially, they're a little piece of the cell that contains the cytoskeleton of the cell and the phospholipid bilayer. And typically, on a fair number of these, the phospholipid bilayer will be flipped so that the normal anionic phospholipids that are on the inside are now on the outside. And they're small. They're less than a micron. That's going to be the problem. So how do you form these things? Well, they can come from a variety of cells. Triggers can be things like cytokines activating a monocyte to release them, or it can be platelet activation from thrombin or something else, shear, and the platelets will release them, or it can be something like thrombin that's activating an endothelial cell. So any of these cell types potentially can release microparticles. When they get activated and are released, there's generally an increase in intracellular calcium. Like I said, this is an important one. Change in the membrane lipid symmetry, generating a procoagulant particle, and cytoskeletal protein reorganization. So that you can take a nice discoid platelet, and when it activates, I'll show you some pictures of that. This is an example. You start with the discoid platelet down here, and then when the platelet activates, it starts to spread out to cover up the wound. And then you see, if you go later, these sort of stellate-looking platelets. Well, if you do it quick enough, and you do studies where you stop them at sort of intermediate points, what you will see is little blebs on the end of these spicules, and these little blebs come off. And at least for platelets, that's what looks like where the platelet microparticles are coming from. So there's been a number of studies on this over the years. A couple of the interesting ones, there was a study using atomic force microscopy where they took platelets and they activated them and they kept essentially taking pictures of them. And what they saw were that platelets activated in vitro produced large numbers of microparticles that were about 100 to 150 nanometers on average in width. So they were pretty small. Another study went out and they actually coated slides with an antibody against platelet antigens, and they trapped the microparticles on the slide. Took plasma, no platelets in it, and so they captured these things, and they found that plasma, using atomic force microscopy, contained about 200,000 platelet microparticles per microliter, and that they were in the range of 10 to 400 nanometers in width. And there was another study sort of looking at this with transmission and scanning EM that looked at patients that had heparin-induced thrombocytopenia. So they took plasma, sera from those patients and added it to platelets and then looked to see what happened. And this is an example. These are resting platelets. And then they've added heparin and serum from a patient that had heparin-induced thrombocytopenia, and the platelets activated and showered off all these little blebs. This just shows controls they used with thrombin and ionophores, that they got the same thing with other things. So in HIT, if you activate platelets, they shower off all these little fragments. So what could these things be doing? Well, maybe they're signaling things like immune response or inflammation or repair mechanisms. Nobody's quite sure. Some people think that they accelerate hemostasis. They might also have been proposed that cells may try to shed pieces off of them where the phospholipids have already been flipped out. Nobody's quite sure. What role do they have in cancer? Not really clear. And I'll show you why some of this is a little unclear in a minute. This was kind of an interesting study. This was an in vitro study where they essentially took a normal pig artery wall and then they flowed blood over it. And then they just essentially kept sampling and looking at it. And what they saw was that tissue factor started appearing on the surface of the pig artery wall. It's all the sort of immunostaining here. And that they saw this being delivered by sort of activated monocytes and other cells, but also they would see these small particles essentially collect on the wall, and these particles were tissue factor positive. So they were arguing that one of the things the microparticles do is they actually accelerate hemostasis by coming to the site of a wound and bringing tissue factor to it. Now, if you go to some of the thrombosis meetings, this is a controversial topic, and they will just tear each other apart in the meeting. So one guy saying this is a wonderful thing and this is what's going on, and the next guy getting up there and saying, no, it's all a bunch of garbage. So what's happening here is still a little mysterious and hasn't been worked out completely, but there's a lot of other sort of interesting pieces in this microparticle story. A lot of people have looked at microparticles in coronary artery disease, and they've looked at two types of microparticles primarily, platelet microparticles and endothelial microparticles. And you can sort of see from this summary, a couple of studies have found an increase in the platelet microparticles associated with diabetes or with acute coronary syndrome. But a number of studies have found elevations in the endothelial microparticles. They've seen elevations associated with venous thrombosis. They've seen it with diabetes. They've seen it with coronary artery disease, acute coronary syndromes, and stroke. So there's a lot of interest on the cardiology side of things to look at endothelial microparticles and whether this could be an assay that essentially measures either the activation or the injury state of your endothelium. So for the first time, we might have some kind of an assay to tell us something about endothelial state that we could measure in the lab rather than doing just angiography or something. So I'll highlight a couple of sort of articles interesting on this. So this is one study, for example, looking at endothelial microparticle counts in plasma. And what they found was that they were much higher in patients that had coronary artery disease. And they even differentiated between acute coronary syndromes and stable angina. And there was even some separation, if they looked at it that far, between individuals that had myocardial infarction versus unstable angina versus stable angina, et cetera. So it was interesting that there seemed to be a separation in sort of the risk state, you might say, in coronary artery disease, and the microparticle, endothelial microparticle levels sort of predicted this. So you might have an assay that could sort of predict what your sort of risk of having, now what you'd want to do is just in advance to see if there's somebody that hasn't had an MI yet or hasn't gone into unstable angina or something else that they're heading towards that. So could this be a predictive test? Platelet microparticles were also elevated, but they tended to be elevated only in the individuals that had a more severe form of coronary artery disease, myocardial infarction or unstable angina. They didn't separate sort of stable angina from control like the endothelial microparticles did. Another study looked at individuals that had sort of high risk versus low risk lesions on angiography, and this study again found that elevated levels of microparticles, endothelial microparticles in the blood were associated with the high risk angiographic lesions or with lesions that had a thrombus on them. Now I'll just mention at this point to note that the level of these things they're measuring in these studies are typically about 1,000 to 2,000 per microliter, okay? So remember that for a minute. The typical level of microparticle we're kind of finding in these studies is 1,000 to 2,000 per microliter. In cancer, microparticles have sort of been around for quite a while. All the way back to 1981, it was described sort of in vitro that cancer cells would shed little fragments of themselves. More recently, they proposed a link between sort of circulating tissue factor coated microparticles in cancer and thrombosis. Another study sort of linked tissue factor bearing microparticles in cancer and venous thromboembolism. And this is sort of a slide from that study. And up here you can see the size of the microparticle on the x-axis, and it's hard to see, so I'll tell you this is about something on the order of 0.4 to 0.5 microns is right down here. 1 micron would be way up somewhere here, so most of these things are small. They're on the order, like we showed from the atomic force microscopy stuff, on the order of like 0.3 to 0.4 microns, so they're pretty small things. What they found is, in this study, this was using a modified flow cytometer designed to see much smaller things, that they were seeing a lot of them. They were seeing on the order of hundreds of thousands to millions of these things. Now remember, when they looked for platelet microparticles just in plasma, they were seeing on the order of 200,000 platelet microparticles using atomic force microscopy. So if you wanted to routinely determine the number and cell of origin of small particles in blood, what would you use in lab medicine? Flow cytometry, right? I mean, that would be the guess. We're not really going to go out and use atomic force microscopy. I mean, these guys did a lovely job. They studied about 10 patients in their paper very painfully and got very interesting data, but it's just not guessing we're going to put that online. So several years ago, and for unfortunate residents, I started trying to measure microparticles with flow cytometry. And what do we find out? Well, the darn things are small. They're less than a micron. Whereas the other things we're looking at are huge. So my new world is that red cells are giant balloons, and monocytes are so big I can't even fathom them anymore. Okay, and so these things are tiny. And the particle size, this was one thing that's just sort of appeared recently. If you wanted to figure out how big the things are, typically what we do is we use forward scatter. How much light they scatter sort of in a forward direction to estimate what the size of the particle is. And so if you wanted to calibrate it, what people have done is they've used little microspheres or beads made out of polystyrene or something, and they've put those through the flow cytometer and said, okay, this is a bead of known size, this is a 1 micron bead, this is a 0.5 micron bead, this is how much light it scatters, and then they set their gates in the flow cytometer. Unfortunately, none of us really looked at light scattering theory enough at that point, although I'm deeply into it now, and found out that polystyrene scatters a lot more light than does lipid. It scatters about 25 times more light than lipid does. So the problem then is about a 0.4 micron polystyrene bead is scattering about the same amount of light as a 1 micron microparticle. So everybody that's been using these gates has actually been looking at microparticles that were a lot larger than they thought, about twice as large. So they thought they were looking at 1 to 0.5. They were literally looking at 1 to 2, which means what they were looking at is little platelets. And so guess what? They find lots of platelet microparticles. Okay. So this shows sort of a comparison in this study where they looked at platelet microparticles with atomic force microscopy, so they could see things down to about 10 nanometers in diameter. And again, they found about 200,000 microliters, and then they tried flowing the same samples with the same antibody through an LSR2, and they found 400. And the only thing they were seeing is the edge of them that was large. The biggest things they saw, which was, you can guess, it's less than 1%. Now this is the other thing that would just bring tears to me when I would start reading these papers. We went out and all I wanted to do was, what's the normal level of microparticles in blood? Just the normal level. I don't care about disease or anything else. What's the normal level? We all like normal reference ranges, right? So this shows the normal reference ranges from, I don't know, what is it, multiple studies. One guy said there's about 200 per microliter, 80 are platelet, 2 are tissue factor positive. Same group a year later said, no, there's 700 in there and 26. Now it's gone up tenfold, okay? This one said, no, there's 200 platelet microparticles and 47 per microliter or tissue factor positive. These guys said, nah, there's about 2,000 per microliter. These guys said, no, 95 and 347. Then they came out and said 200,000. And then these guys came in and said, no, you're all wrong. There's about 10,000 tissue factor positive microparticles. So you can see that the literature has not quite come to grips with this. Some think there's 2 per microliter that's normal, and some think there's 10,000 per microliter that's normal. And so we spent a few years fooling with this. So there's some new flow cytometers, though, that have come out designed to look at little things. One is a modified Beckman-Coulter Quanta, and another one that we've gotten is an Apogee called the Apogee A40. These systems typically detect about 100,000 to 10 million microparticles in plasma rather than 1,000 per microliter. So roughly speaking, it looks like when you're using the LSR2, you're off by about 1,000-fold. So it isn't like 10% or 50% or twofold. We're off like maybe 3 orders of magnitude. So what's happening? Well, this sort of shows you an example. So what we've done here is put a series of polystyrene beads at different size through the Apogee and through the LSR2. And so if we look at the LSR2, here's an 800 nanometer bead, and you can clearly see that, and you can see 600. But then when we get down in here, this is a 500, 400, and 200 nanometer beads, and basically they're all one lump. Now the other thing that I can't quite show you on here, or I didn't put it on here, is that if you counted how many beads were actually in the sample, and then you looked at how many you counted on the Apogee versus how many you counted on the LSR2, the LSR2 is only counting about less than 1% of the beads. All it's seeing is the small number of beads that were too big. Get me? So that's sort of what the edge of what it was seeing down here. Now on the Apogee, you can see here's a 400 nanometer bead and here's a 200 nanometer bead. Well, remember we said 400 nanometer polystyrene was about the same light scattering as a 1 micron lipid microparticle. So this is the interesting part, where the arrow is. That's where the microparticles are, between about 400 and 200. Well, that's all just one lump here. The LSR2 just can't see the darn thing. So you're really going to have something else that can see this area if you're actually going to pull out these things. So one day in the lab, we got this thing, we were playing with it, and then I said, let's just put some plasma in it and see what happens. Not even labeling it or anything. We're just going to take a plasma sample. We'd run these things on the LSR2. We were getting the typical kind of thing, 1,000 per microliter microparticle. We put it in here, and all of a sudden, what did we get? The first one we ran had 1 million per microliter microparticles, so 1,000 times more. So the trick is, the LSR2 is seeing this part of what's going through it. It's right down here. That's what it can see. And what it misses is all of this. Now realistically, this is sort of the threshold where we can't see smaller than that because you start running into the noise limits of the flow cytometer, okay? So my guess is that this distribution really doesn't stop here, that this isn't really the shape of the curve, but the curve is actually coming down like that. And we're guessing maybe about half the curve. So there's probably twice this many, and a lot of them being smaller. So this is sort of really a new world. This has really only been in the last 2 years that using these atomic force microscope methods or these newer flow cytometers that people have really started to come to grips with how many of these things there are and exactly what are they. We've stained a few of them for platelets, and we're getting about the same kind of numbers they got off the atomic force microscope studies now, that we're seeing, in the range of 100 to 200,000 platelet microparticles in plasma. And we're starting to work through the issues of trying to figure out how many of them are endothelial microparticles or red cell microparticles, if it was like an old unit of blood, or from any of the other cell types. So it's really kind of one of these new things where you've stepped onto the shore and nobody really knows what's in here, and you don't get to see that very often in science. Usually we're chewing away on something. I mean, I guess the microRNA is another world like that that's out there. But from this world, it's sort of interesting that we've got something new to play with that nobody's really quite sure. Because what we've been looking at before was literally less than 0.1% of what was actually there. And it may not represent the same population even as what you might call the true microparticle population, because it looks like a lot of what they were seeing is actually small platelets and maybe other small cell fragments that aren't the same mechanism of release. So anyway, that's for conclusions. I think the thrombin generation and microparticle assays show promise for evaluating a number of prothrombotic conditions, trauma, heart disease, cancer, but they're poorly understood at this point. Whether they're really going to turn out as a clinical assay, I don't think we know, but they certainly look like they're a good research opportunity. If ongoing research supports their value, they may become a new clinical assay, which really provides in a clinical laboratory opportunity. Kind of like BNP a few years ago, where we didn't have a test to measure congestive heart failure, and now we have something that's routinely measured a lot because it's a lab test. So if you had a lab test that could predict venous thrombophilia or sort of venous risk or arterial risk, then I think the potential for these things is big. I always remember when I sat down with Paul Strangeard, like about 25 years ago, when I was an assistant professor, and he said, I'm finally getting around to this, he said, Wayne, if you're going to study something common. Now, I know you've all studied, sometimes things that are very uncommon and made it wonderful, but he said, if you study heart disease, a lot of people have it, might come up with a good lab test. So, Paul, I'm sorry, it's still there. 25 years later, I'm still working on it. Okay. So anyway, any questions?
When we die, they can just turn into a massive packet of microparticles.
I think that's it, Bob, that when we die, that's what, it may take a while, though. I think we're sort of one big microparticle at the start, and then we get into smaller ones.
So when you kind of alluded to this at the end, but we don't really know the distribution of these things. Maybe they're smaller. You get next year's instrument. It's great for the lab, and everyone's excited with the new thing. You can see the smaller ones. But ultimately, I guess what you're really concerned about is what they're doing. So my first thought was maybe you ought to go back to a functional test. Are they procoagulant? What are they doing rather than just counting smaller and smaller ones? Unless there's some way that you're actually able to look at the phenotype at the same time you're looking at these, or you didn't get into what else you can do with this instrument beyond just count.
So it's a good question. The question is, could we have a functional test for what the microparticles are doing in addition to just counting them? And the answer's, yeah, I didn't talk about that, but we've got a whole other side of the thing. So the thrombin generation assay is one form of functional test. If you actually spin these things out and wash them, like in an ultracentrifuge, and then you spike them back into plasma that's normal and shows no activation, you can show that these things are procoagulant by themselves. So you can count them and say, I got this many of these things, I spiked this many back into plasma, and they will activate the thrombin generation assay. The other things we've been working on are to try to look at an activity phenotype, just like you're talking about. So one version of this are assays that measure the procoagulant activity of the microparticles, because they tend to have an annexin 5 binding surface, an anionic phospholipid surface. So we've got a series of assays that we've been working on to try to measure the procoagulant side. We've got another set of assays to measure sort of tissue factor activity. It turns out that there's potentially other things out there like activated circulating activated factor 11A may be binding to these things or may just be circulating. So there's a series of assays coming out now that are doing exactly what you've said. Some people have actually tried just measuring the microparticles from purely a functional method, and so they use a plate to essentially bind them out. And one way of doing this is basically coat the plate with an Xn5 and see if you can stick the ones down that are already positively charged, or excuse me, negatively charged. And then they do some form of functional assay in the ELISA plate. So there's a whole literature out there of trying to understand what they're doing as well as how many of them and putting the two pieces together.
I've got a follow-up question to that, which is, do any of these new flow cytometers sort? Can you sort microparticles? So not only looking, just not spinning them down bulk, you separate the ones derived from, let's say, from platelets from those derived from monocytes, et cetera, and functionally assess the differences there and see what's inside of them. You know, are there particular proteins or microRNAs or whatever?
The question is, in a sense, can you sort microparticles using a sorting flow cytometer? I have never seen anybody that's done that yet. It's so new that they're this size that I don't think anybody's tried it.
Is there much known about the generation of these things in vivo, such that maybe in the assay where some people did it in vitro and saw cancer cells, is there a drug that can either make more of these microparticles get made or inhibit the production of microparticles?
There's not much on what the actual mechanisms of production are in vivo. There's a number of studies that have looked at it a little bit in vitro. It's a little bit easier there because you could collect them in a sense. Partly I think it's because, like I said, it's really only in the last 2 years that people have decided that there's a lot of these things, not just a few of them, and they don't know what a lot of them are, and they don't even have observational studies yet of how many of these things are present in one form of cancer or another. Another thing that people are interested in is cancer microparticles. You know, in other words, looking at these things not to come from platelets or endothelial cells, but to come from the cancer cells. How many of those are circulating? So there's just a whole range of studies out there to sort of sort this out.
Just thinking about sort of the functional effect, and for coagulation, you know, it's probably going to depend on the surface area that's available. So what that means then is a microparticle that's 10 times the diameter of another one actually has 100 times the surface area. So is there any sort of thought of or any evidence that sort of the per particle effectiveness is going to vary on the size of the particle, and therefore you have to sort of calculate that when you're trying to sort of say, instead of just number of microparticles, it's the amount of surface area that counts.
So the little microparticles don't have much surface. So the question is, are bigger microparticles more effective because they have more surface than little microparticles, which would have a lot less surface if surface was important? And that's quite possible that's true. We've been working on two different procoagulant phospholipid assays, and I won't bore you with the details of them, but one basically binds it to the surface and another one sort of does it in a clot-based method. And that assay gives us 10 to 100 times different levels of apparent procoagulant phospholipid. And we've wondered if it's because one is measuring mostly the little ones or something, or pulling out the little ones. So I don't think that's another piece of the puzzle that isn't understood. Maybe the little things don't matter. They're just garbage circulating and they're too little to do anything. And it's only the big ones that matter. I'm sure the guys that have only looked at the big one would love that argument, because it means everything they've done hasn't been garbage all these years. If it turns out the little ones are still important in some fashion as some kind of signaling, well, so nobody, again, it's a lovely question, and the answer is I don't think anybody knows.
How are microparticles cleared? Are there any ideas? Are they found like in urine or other fluids?
How are they cleared? They don't know. The study suggests that their half-life isn't that long, at most on the order of hours, certainly not days, and maybe in some cases only minutes. But again, all they've done at this point is said, wow, this is how many's there. And nobody's really looked at it very much. We looked at this in just in a few cases in patients who were undergoing cardiopulmonary bypass, and they shower off these things, and then once they come off bypass, the numbers fall over the next hour or so. So it suggests crudely that their half-life is going to be on the order of maybe an hour or something, or two, but not on it doesn't look like it's going to be a much longer half-life. So they must be continuously being produced, is the guess.
So I was a little bit surprised that you were courageous enough to say that you understood the distribution of the microparticles and that you were measuring about half of them. If you use atomic force microscopy as the gold standard, is that what you're basing that half on?
Yes.
Okay.
So the question is, why are you standing up here saying you think you know you're measuring half of them, when that could be completely wrong? And I totally agree, I could be completely wrong. So the studies looking using an atomic force microscope, they could see anything from 10 nanometers to however big it was, 1 micron. And they said the distribution is like this. And so then we looked at essentially the same kind of thing, and we see, and they said this is about the peak of the population. Well, we're seeing about the same peak they are. Well, assuming that peak we're seeing is about the middle of the distribution, then the numbers would roughly be about right. So we're guessing that we're seeing about half of them based on the atomic force microscope data, and then what we can see once we've calibrated the sizes we're looking at.
Is there any way to tell apart by flow cytometry these microparticles, the way that we define them as like vesicles or bound by cell membrane from, let's say, cell membrane fragments secondary to artifact or mechanical rupture of the cells?
At this point, no. We don't know what the mechanism is exactly.
So follow-up question. Now that we are aware that microparticles are probably a lot smaller than originally defined, how do you distinguish microparticles from exosomes, which could be as big as 100 nanometers?
Well, and they probably overlap. So I think, that used to be that microparticles were sort of, 0.2 to 1 micron, and exosomes in the papers were something slightly smaller, and they had this nice division. Now it's a big mess. So it could be, these things could be blebs off the surface, or they could be an intracellular, fragment. In other words, some kind of an organelle from the cell, like an exosome or something else, or they could be some injured cells may produce these things, as well as apoptotic cells, and some studies have shown that they release them, and activated cells. So all the mechanisms. One study looked at endothelial microparticles and said that they had a different endothelial phenotype, whether they came from an apoptotic process or an activation injury process. Thank you.